All right. So thanks again, Fraser, for the introduction, and thanks everyone for joining. It is my absolute pleasure to be able to introduce Dr. Nitin Ohri as our webinar speaker today. Dr. Ohri comes to us after completing training from Thomas Jefferson University and is currently an associate professor at the Montefiore Einstein program in the Bronx. He has expertise in treatment of lung and liver cancer and is the director of their research program. And today he will talk to us about the fascinating and innovative work that he's done on wearable technology in cancer patients. We've heard this talk about 2 years ago with an ACRO webinar, and it was really fantastic and the feedback was excellent. So it's a real honor and privilege to have Nitin return to us to give us some updates on that work. So without any further ado, thanks so much, Dr. Ohri, for joining us. All yours.
Oh, thank you, Dr. Bernstein, for the kind words, and thank you to you and the rest of the organizers for inviting me to speak again. Now, I did speak a couple of years ago, so I hope to share what we've been doing, in particular some updates, and sort of put things maybe into context of where I think things are today and where I hope they're going in the near future. So with that, I'll begin talking about wearable devices in oncology, the current evidence, and unanswered questions. Here are my disclosures. It's a continuing trend, as you're all aware, for wearables to be more and more ubiquitous in our society. We, on the top here, I just showed some financial data showing the projected growth of the industry over the next 6 years or so. And you can see, of course, the most common wearable device is on the wrist, but there are some others that are coming up. Now, this is measured in terms of dollars, so it may be that the wrist-worn devices are cheaper, but actually even more prevalent than shown here. On the bottom, I did some quick PubMed searches looking for studies that seem to be using wearable devices in medicine. You can see it's up to the thousands per year in general, and specific to oncology on the order of hundreds per year. So certainly it's a growing area of interest, both for commercial reasons and for science. Now, how can we use this technology with wearables to improve cancer care? And I'm just trying to hide my panel. So the way I like to think about this is sort of in a temporal fashion of what can we do with wearables before patients start treatment, during treatment, and after treatment. And I think there's potentially an important role for these devices in each of those settings. Now, before treatment, we could use wearables to enhance our assessment of the patients and select patients who are fit for aggressive treatment, perhaps identify patients who are better served by less aggressive treatment, and really customize what we suggest for our patients. As our patients are going through treatment, and that could be local therapy with radiation, surgery, or systemic therapy, I firmly believe that wearables will help us evaluate our patients subjectively in real time and continuously to improve the supportive care we can provide for patients with declining functional status. And then after treatment in the survivorship setting, changes in parameters measured by wearables could indicate late toxicity or disease progression. And wearables could also be leveraged to promote healthful lifestyles, increased activity in the survivorship period, which would also stand to improve outcomes. All of this, in addition to improving the clinical outcomes we achieve, should, if done correctly, reduce healthcare expenditures and improve the quality and value of the care we deliver. So what are we to do? And this is a very busy slide, but it sort of summarizes the way I've been thinking about things, and I'll point out exactly what we've been doing in the Bronx. So just thinking of sort of the basic questions. Which patients could benefit from the implementation of wearables in their care? You know, there's situations where I think any cancer patient could benefit. Obviously, different patient populations have different journeys. Some are destined for relatively easy treatment courses, and some are likely to suffer severe toxicities. So the ways the wearables could be leveraged would vary. In terms of what the devices are, there's dozens of different types of devices out there. I've been using devices more on the wrist for the most part, but other groups have been exploring things with rings and sensors on the hips. And smartphones themselves are very powerful and can do a lot and collect a lot of data. Each device, of course, will give a different menu of metrics with things like heart rate variability, step counts, sleep metrics, pulse oximetry, and that menu keeps on growing. Again, when should we implement these measures? Before, during, or after treatment would all be potentially beneficial. And as I mentioned, surgical, radiation-based, and systemic therapies could all perhaps be enhanced if we leverage these devices appropriately. And what can we do with this new information, with these new metrics? They could serve as new prognostic factors, new vital signs. They could be the thrust of an intervention where we try to increase or change patients' physical activity. And we could also consider using these metrics as an outcome. We're comparing two treatments. Perhaps it would be of interest to see which treatment leaves patients with a higher functional output during and after treatment. So putting this all together, there are literally thousands of studies that could be done, and we've started to do a few of these in the Bronx. So just to put a little finer point on that, as Dr. Bernstein mentioned, I do spend a lot of my time treating lung cancer patients. So our device trials have largely focused on lung cancer, but also other solid tumors, head, neck, GI, and a few others. We've also started studying some patients getting systemic therapy, not just radiation. As I mentioned, I've mostly been using these wrist-worn devices that are relatively inexpensive and user-friendly. Mostly I've been focusing on things before treatment and during treatment, but we're getting more and more into the survivorship setting. And I think already we've generated some interesting evidence suggesting that activity data can serve as prognostic factors, vital signs, and perhaps even as a form of intervention. And we're trying to generate some data showing that wearables can also be used to develop outcome measures. So here's a busy table summarizing the studies we've been running over the last 6 or 7 years or so, starting with some pilot studies for head and neck, lung, and GI cancers, moving to some interventional trials, asking patients to walk more if possible, moving into the space of patients getting treated with systemic therapy for advanced disease. And also in recent years, we've been using wearables as to sort of fuel endpoints in therapeutic studies, some with pharma funding, some with NIH funding, looking to, as we try out these novel combinations of radiation and immunotherapy, demonstrate how well tolerated they are by using wearable device data. And then upcoming studies include some collaborations with our Proton Center, a multi-institutional study supported by the NRG Foundation, and a follow-up study to our first Merck-funded study looking at radiation and immunotherapy for lung cancer. So in total, we've had 200 to 300 patients wearing devices over the years and have a lot of interesting data, I think, to share. So I'll get into some of that. So the devices we've been using for the most part have been the Garmin VivoFit, which is one of their sort of lower end, more affordable activity monitors worn on the wrist. It serves as a very functional, simple pedometer. Some of the benefits of using this and why we chose this for our patient population: it's waterproof. It uses a watch battery that lasts at least a year without any charging, and patients essentially can put it on and forget about it. For a time, we had these devices installed in our clinics that would download the step data automatically every time a patient walked through the waiting room. So that sort of streamlined the collection process for data. These devices happen to hold data for about 3 weeks. So even if a patient was just getting seen once a week for status check or every few weeks after treatment, we were able to collect lots of data without really needing the patients to do anything aside from keep the device on. Some qualitative lessons before we dig into the real data. We found, at least in our setting and the way we implemented these devices, we found that feasibility was generally there. Most of our patients are willing to wear a device. We said, here's basically a watch, you can keep it free of charge, and they would accept it. Many of our patients, however, are not really interested in engaging with the device. In some of our later studies, when we asked patients to increase their activity or look at the step counts, that's where we started to sort of lose patients in terms of their participation waned and their interest in doing what we told them was not quite there. But that being said, we still have found very early on, and it still bears, that daily step counts, I think, are incredibly helpful. They're easy to collect. We all kind of are used to thinking about step counts and easy to interpret. I found that they're a new dimension of information. They're not predicted by age or performance status or comorbidities. It's really a new piece of information, or potentially a new vital sign, if you will. And even in our first small studies, and certainly in our bigger studies, we found that step counts are clinically relevant. Pre-treatment step counts, I think, can be an important prognostic factor. And during treatment, changes in step count can serve as a new vital sign that I think is just as good as any other. And this is all just with daily step count. So as we get to more advanced devices with things like heart rate variability, I think we'll be able to do even better. So first, focusing on some findings in the pre-treatment setting, just to put things in context, generally for a patient getting radiation or chemoradiation, we would try to consent them around the time of first consult or simulation and get them wearing the device then. So we'd have about at least a week or so of lead time before they start therapy. So just thinking about a patient's evaluation before treatment, some of you may have heard this recommendation that people should be walking 10,000 steps a day. This is actually a very old idea from the 50s in Japan. These very simple pedometers from back then were actually named after the idea of being able to walk 10,000 steps. Recently, or more recently at least, people have realized that 10,000 steps is pretty much a lofty goal for a lot of the types of patients we're seeing. Anybody who's older or living with a chronic disease is unlikely to be able to achieve that baseline activity level even before starting any aggressive treatments. So I did find this helpful resource a few years ago. This was a study done in Australia for people without any specific cancer or other diagnosis. But it was done with thousands of patients, or hundreds of patients at least, and provided some really detailed information regarding their daily step counts. So the first thing I'll point out is that step counts, so if you look at the 50th centile, they call it, or the median, declined dramatically with age. So people in their late 50s were averaging 8,600 steps. And then if you were in your 80s, you were down to under 4,000 steps, so less than 50%. And that's something that's been reproduced in lots of settings. It's just natural. With time, people are generally less active. Another thing that they showed here that we've also noticed in our Bronx data is that patients tend to be less active on weekends. So certainly when looking at trends, I think it pays to average data over a few days, at least 3 to 5 days, and also perhaps even compare sort of with an adjustment for day of the week. So looking at this, I thought if we're going to try and apply this data to our patients, albeit in the Bronx, not in Australia, it might be helpful to come up with some categories. So sort of in an arbitrary fashion, I decided that patients who are under the 25th percentile based on age prediction would be called inactive. Patients above the 75th percentile would be called very active, and everyone in between would call just active or moderately active. And here's what happened. So this is data from our first 200 patients or so who were given wearable devices on one of our first 3 studies. What we've shown here in the y-axis is the step count average before even starting treatment, and the treatment here was chemo or radiotherapy given concurrently for one of these diagnoses. And if you plot the step counts against age, with each of these dots or each of these symbols being one patient, you find that actually a majority of patients end up being in the inactive category. And you get about 20-25% each in the active and very active categories. Also, if you look here, I've annotated it by the performance status that was ascribed by the physicians before starting treatment. And you'll notice there's a lot of people with performance status 0 who are way down here at the bottom with very low step counts, even some who aren't too old. People in their 40s with step counts in the 1, 2, 3,000 range who are very, very inactive. And if you think of what performance status is supposed to mean, we'll see that we're really not ascribing performance status in an accurate fashion in clinic. Maybe not a surprise. Here's that data in a different form, just to show that the difference of, if you look at the performance status 0, 1, and 2 patients, you do end up with a wide variety of activity levels in each category, especially PS0 and PS1. PS2, you still have, it doesn't really mean exactly that you're inactive, but I will say that patients who we deem to have a PS2 are very unlikely to be very active. And so what does this mean? One of our papers that got a good bit of attention a couple of years ago was looking at our lung cancer patients on these studies. So a cohort of 50 patients from that first 200 patient cohort who were treated with chemoradiotherapy for locally advanced non-small cell lung cancer. And just using that simple breakdown of inactive compared to the other two groups, we found that it had tremendous prognostic value. So about a third of patients were inactive, and those patients had a very high rate of hospitalization during radiotherapy, 50%, compared to just 9% for other patients. They were very likely to have a delay in the radiation, so only 67% completed radiation without a delay of a week compared to 97% of the other patients. And then the clinical outcomes actually were also quite impressive. You look at the PFS curves on the left and the OS curves on the right, dramatic differences and expectations. So this, I think, we're looking to validate this in some bigger studies, including the next NRG study. But I think it stands to reason that this will very quickly outperform performance status in helping to decide on our patient's prognosis. And perhaps one may even argue if you have somebody who's really inactive, they're very unlikely to tolerate aggressive concurrent therapy and may better be served by a different treatment approach. So just maybe flipping the question on you guys who I presume are not using these devices routinely yet in clinic. So now I've taken those 50 patients and put them on that same kind of plot. So this is the performance status, and most of these patients were treated by me. So here's the performance status I gave them after meeting them compared to their step counts. So again, essentially I do a very bad job of identifying which patients are high performing or highly functional. And think to yourself, how good a job are you doing in understanding your patient's functional status? And if you have a patient in clinic tomorrow who has a Fitbit on or a Garmin or some other device or an Apple Watch, would it be worthwhile to ask them, hey, what's your normal step count at the end of the day? I think it might be interesting. So moving on to the during treatment setting, and this is where, of course, we've been focusing a lot of our work. As we know, patients getting chemo and radiation are at high risk for a lot of different adverse events and treatment interruptions. So looking back at our first pilot study, which is 38 subjects, what I'm showing here on the right is what we call a spaghetti plot. So each line or each curve here represents one patient. It's actually the data itself, the raw data is even wilder than this. This is using a 3-day smoothing function. But you can see in each of these little triangles is a hospitalization event. So 14 out of only 38 subjects in our patient population ended up getting hospitalized during the treatment course. And you can see that the triangles are clustered near the bottom, this meaning patients who are not moving much are at risk for hospitalization. If you're keeping up during chemoradiotherapy, if you're keeping up 6, 7, 8, 10,000 steps a day, yeah, you may not be feeling perfectly well, but at least you're probably in the clear and not going to end up in the hospital. Running the regression model showed a very dramatic 38% reduction in the risk of hospitalization for every 1,000 steps you're taking. So very powerful just with a small pilot study and only 14 events, a highly significant p-value. We repeated these analyses in our bigger data set of about 200 patients and essentially found the same thing. Both low step counts as well as declining step counts actually are risk factors for hospitalization in the next few days. If you break it down by recent performance status, patients who are, if we see a patient in clinic and say, okay, looks like you're doing great, performance status of 0, but they happen to be inactive and with declining activity level, they're still at risk for hospitalization. Same thing, all these patients in the first few studies we've done have completed the EORTC QLQC30 quality of life form. And if you look at their numerical quality of life, at that last status check, that is not a predictor of if they're going to end up in the hospital, but the step counts are. So to me, this is very telling that the objective data outperforms what the physician thinks of how the patient's doing, and even perhaps outperforms how the patient reports are doing themselves. And so our second study, the follow-up to the pilot study, was really looking to leverage this and try and improve outcomes, and specifically trying to keep patients out of the hospital. So we ran another study with about 40 patients looking to reduce that hospitalization rate, where we saw in the first study, 14 subjects were hospitalized, and we thought we could reduce that by using an enhanced and sort of opportunistic intervention. And our intervention was simple, but maybe a little too aggressive. We were looking at patient step counts every Monday, and based on the activity over the past weekend and comparing it to the weekend before, we had a simple cutoff to decide if we thought the patients were at high risk for ending up in the hospital. And so if we deemed a patient to be at high risk for hospitalization, we would try to see that patient instead of just once that week for status check or OTV. We would try to see them every day. And we would also try and coordinate, if needed, pain management, evaluations, or physiatry, and all kinds of things. And you can see here what happened. Again, this is the next set of patients in our second study, but it looks pretty similar. Still a bunch of triangles, meaning a bunch of hospitalizations, still clustered in the at the bottom where patients are not moving much. And so we did not meet our endpoint of reducing the hospitalization rate. And we did learn some things. In particular, we learned about some of the logistic challenges of changing the workflow and how we really need to be smart about this and anticipate what the problems that will happen in a real life clinic. So some things that happened, we found that when we met a patient on a Monday or saw a patient on a Monday and said, hey, you look to be in trouble, let's get you a palliative care referral, let's get you PT, let's get you whatever we think you need. Things didn't move that quickly, and often the visits never happened before the patient ended up in the hospital. Similarly, we might see a patient say, okay, you're in terrible pain from your esophagitis or whatever else is going on, mucositis, dermatitis. Let's get you some better pain medications. But a lot of the local pharmacies at the time may not have the medications in stock or may not dispense them right away. So our patients still ended up in the hospital. And sometimes we'd have patients who did not even want the extra attention. They found that they didn't want to be seen every day. They were busy with transportation issues and family issues, and actually those are the few subjects who actually took off their device and yielded some missing data. Moving on to think of sort of why patients become inactive during treatment. Certainly, this is going to depend a lot on the exact organs that are being irradiated and what are the side effects that are taking place. Going back to our lung patient population, we did an analysis that Dr. Paul, one of our former residents, put together that I thought was interesting and actually quite surprising. Treating lung cancer all the time, I thought that the esophageal irradiation would be the main culprit. Patients get esophagitis, don't eat, end up in the hospital. If not that, I thought maybe lung irradiation, they're not feeling well, impaired lungs, and get some dyspnea and end up in the hospital. But actually, it was the other organ at risk. It was the heart. So for this study, we looked at daily step counts during the course of chemoradiotherapy for lung cancer. For each patient, we applied a regression to kind of come up with a percentage change per week, and that's shown here on the left. And then we just plotted that change for each patient against the various dosimetric measures. And the one that actually stood out was the heart dose. That for every 10 gray increase in heart dose, you'd end up with a shift or a decline in your step counts of 3% per week, which as the weeks go on certainly adds up. And that's, I think, was really surprising. Of course, cardiac toxicity is getting a lot of attention over the last 5-10 years in thoracic oncology. Surprisingly, to some, it was a big predictor of survival in RTOG 0617. It's been found to predict cardiac events and lots of other studies. But to me, this is a real indication that even in the short term, during treatment, somehow cardiac irradiation is harming our patients. This was in contrast to these patients, what they reported with quality of life in terms of fatigue scores. It was not due to anemia. So really, it's a phenomenon we're looking to learn more about in our next studies. So one of those other studies, we're going to transfer this work in some sense and go to the New York Proton Center, where we are fortunate to collaborate. Of course, when you think about cardiac irradiation, that's something that will happen to a much lesser extent, usually with proton radiotherapy. So here we're looking to pilot these, run a new pilot study using wearable devices. In this case, we're going to upgrade to an Apple Watch, and also we're going to incorporate daily pulse oximeter use with a fancy home pulse oximeter, as well as a weekly electronic patient-reported outcome collection. So this, of course, will be a bigger ask for the patients needing to have smartphones and be able to charge things. But we're hoping to collect a lot of data and really tie it all together, see what's going on from the patient-reported outcomes, the functional data with the steps, and also the patient-reported outcomes and the pulse oximetry, to really get a sense of what's happening to our patients during chemoradiotherapy, and also tie those effects to specific organs at risk. So this is something we're hoping to get started. If SIRE will be approved, and it should start any day now. Here are the devices we'll be using: Apple Watch, as well as this home pulse oximeter and study provided iPhones. Moving on to yet another study that we did in the Bronx, and we learned a lot, but didn't quite achieve our main outcome. This was a nice opportunity we got with some funding from ROI, which is a great organization that we should all support. And they supported actually a pretty large randomized trial that we ran over a couple of years in the Bronx. And the idea here was to try and use the wearables and center an actual intervention around the wearables. And the simple intervention we came up with was to just ask the patients to walk more. So these devices provided a daily step count goal based on your recent averages. And we just thought we would ask the patients in the experimental arm to try and look at the device and keep up with the goal that they're provided with. And for the other patients, we just said, just wear the device and forget about it. So the hypotheses in the grant and the trial were that by being more active, we would reduce inflammation. There's lots of studies to that effect, are showing that effect. And that would help reduce treatment toxicity and therefore get us to improve the rate of planned treatment completion, which should downstream improve the treatment efficacy. So we ended up with a pretty big study. We randomized 166 patients with cancers of the brain, head and neck, lung, GI tract, or cervix, all who were planned for definitive chemo-RT or concurrent chemo-RT in the curative setting. And we gave them the devices, and half of them were told to try and walk some more. But unfortunately, here's what happened. Essentially, if you look at the step count averages at baseline and towards the end of treatment, for the control arm and the experimental arm, you'll see there was no difference. The experimental arm and the control arm both dropped down on average, and there was no real sense that the experimental arm patients were walking more. And this was despite every week for patients who are on the experimental arm, the physicians, the study coordinators are trying to encourage the patients, hey, how are you doing? Try and keep up the activity, what's going on, why are you not being active? But still, patients in the middle of chemo and radiation, either they were walking or they weren't. We couldn't really convince them with that very loose intervention of just asking them to walk more. It didn't end up doing much. And as you might expect, then we did not see a change in the inflammatory markers. So despite that, we still had some interesting trends, at least, although not statistically significant. Patients on the intervention arm were less likely to be hospitalized during the treatment course, and actually had a non-significant trend so far towards actually favorable progression-free survival. And this could, of course, with non-significant trends and secondary and exploratory endpoints, could all just be coincidence. But I actually think it may be true that just by having that extra attention for the patients on the experimental arm, with the study team saying, hey, what's going on? Why aren't you walking? Maybe that would prompt an email to the physician saying, oh, this patient's in a lot of pain, or this patient's losing a lot of weight. Maybe that did something. So we're looking forward to, of course, longer follow-up and thinking, importantly, of how we can come up with an activity intervention that's both feasible but actually effective, and that many patients would accept it, but also would actually improve the objective outcomes. In comparison, there was, I think, a very successful study from some researchers out of Duke. So this is from Dr. Julian Hong. He was actually did this as a resident down there. And he had a study that was published in JCO a couple of years ago called SHIELD RT. Many of you may be aware of this already. This was using a machine learning directed intervention for patients who were planned for radiation. And essentially, he built a tool that would look at the patient's information in the EMR and automatically decide which patients were going to be at high risk for hospitalization or low risk for hospitalization during the treatment course. And for the low risk patients, nothing was done. But for the high risk patients, they were randomized to a very simple intervention, just having 2 OTVs that week rather than 1. And here's some of the metrics that went into the model: the radiation schedule, recent ED visits, planned dose, weight loss, age, things you might expect, but nice to see borne out in a machine learning model. And the very simple intervention of just a second status check reduced the acute care visits during radiation by about 50%. So this I thought was a great example of how we can use machine learning and not even wearable device data. This is just EMR data and center an intervention around that. So we're looking to sort of combine forces, and we actually are with Dr. Hong in our next study. So this is NRGF001 that should be opening shortly. It'll be a multi-institutional trial looking to really combine Dr. Hong's model with wearable device data to help our patients get through chemo-RT for stage 3 or locally advanced non-small cell lung cancer. So this is going to be a randomized trial with about 140 subjects. Patients will be randomized to usual care versus usual care plus physical activity monitoring. And here we're hoping to do better than we did in our local Montefiore study. So instead of just looking at a simple metric like step counts, which is sensitive but not really specific for identifying patients at risk for hospitalization, we're going to take the step data and feed it into Dr. Hong's AI-based or machine learning-based models to generate a risk stratification. And subjects who are deemed to be at risk, those subjects, physicians and providers will get an automated email saying, hey, watch out, this patient may be in trouble. And then the clinicians will presumably see the patient and see what's going on and hopefully give them the supportive care they need, if that's pain medications, fluids, nutritional support, whatever it is, to keep them out of the hospital, prevent treatment interruptions, and eventually improve outcomes. So just some contrast to the work we've been doing, and I showed you the study where we tried to make patients walk more and couldn't really do it with our simple intervention. Other people are looking at exercise and intervention in a much more aggressive fashion, if you will. Here's one study that was published last year that I thought was really interesting from a very active group. And they had a study for rectal cancer patients who were getting neoadjuvant chemoradiotherapy, so a patient population we kind of know. And they suggested a very aggressive intervention with through 3 supervised hits, so that's high intensity interval training, treadmill sessions per week, alternating between 85% and 40% of the peak oxygen. So, very aggressive, rigorous intervention lasting for 28 to 40 minutes. So this is a real workout. And it actually, in some sense, the study was a big success, but just one thing to point out, they started with 205 patients screened, but only 36 were randomized. So many patients had contraindications to this aggressive exercise or were not interested or overwhelmed. But what they did find a very interesting, provocative finding that in the patients who were randomized to this aggressive exercise intervention, they actually had an increased PCR rate, which in the paper, they give some hypotheses as to why that could happen. Perhaps, vigorous exercise improves oxygenation or something. But really just an interesting finding. And something similar has actually been seen in a more recent paper in prostate cancer. So maybe there's something to this. More to come, certainly. And then just to talk briefly about the post-treatment setting, this is an area where people are already doing a lot of work. Many of you may be aware of this Alliance study, or called the Be Well study, looking at breast cancer survivors who are overweight or obese, and they're being randomized to a health education control versus a standard intervention plus a more intense supervised weight loss intervention. And that intervention actually does include getting a Fitbit mailed to you and asking you to be more active, as well as some wearable, as well as some food scales and some other things. But the idea here is that by achieving weight loss, or that they hope to achieve weight loss in a population where their cancers are probably driven by ER, or estrogen, they could actually improve disease-free survival through this weight loss intervention. So this, I believe, is actually already completed accrual, and we should have results soon. So just to start to close, I do believe that physical activity is important, especially after treatment. And I think it could be a really important metric when we're trying to decide what's the best treatment for a patient who has a few different treatment options. And There's a few really big studies with thousands of patients looking at the idea of physical activity being a prognostic factor in people who don't have cancer. Here's one such paper from JAMA with almost 5,000 patients. And if you look at the patients grouped by age and steps per day, for patients, particularly once you get above 50, if you're inactive under the 5, 4, 3,000 steps level, your chance of all-cause mortality goes up exponentially. So it stands to reason if we have a cancer patient, we're planning on curing that cancer, and we have a way to cure that cancer that keeps them active as opposed to making them inactive due to side effects, I think that would be a huge win. And even in one of our smaller studies we've done with patients getting systemic therapy for advanced metastatic disease, we found that activity during systemic therapy is a strong prognostic factor. So I think maintaining physical activity could be an incredibly important endpoint to consider when comparing therapies. To that end, we're planning a program in our lung cancer multidisciplinary clinic. Of course, as you all know, there's lots of vigorous debate for localized lung cancer patients. Should they be treated with surgery or radiation? We can argue about stage 1 with SBRT versus limited surgery. For stage 3, should it be definitive chemo-RT versus surgery and chemoimmunotherapy? The randomized trials have not shown that there's any right answer to this. So we're planning a program in the Bronx where in our multidisciplinary clinic, we're going to really examine patients, look at their patient-reported outcomes, look at their physical function outcomes with wearable devices, and really try and fuel some of these causal associations. Why are patients becoming inactive? Is it because of terrible pain after thoracotomy? Is it because we irradiate the heart too much and that causes problems? Is it because they have a large chunk of lung resected or irradiated? So we're going to use several forms of patient-generated health data to establish those associations, and then start an intervention where we look at a patient pre-treatment, say, okay, you have these options, lobectomy or SBRT, or chemo-RT, or surgery and neoadjuvant therapy, and really predict, well, what would the functional outcome be based on these treatments? Where's the tumor? Is it right near the heart? Is it in the middle of nowhere? It should be easy to irradiate. And based on that, we'll fuel an informational intervention to inform the clinicians and the patients of the predicted outcomes, and also implement some timely interventions to maintain physical activity. Do you need palliative care or pain management intervention for your thoracotomy pain? Do you need intense pulmonary rehab? All with the goal of really maintaining physical function to keep our patients active 6 months, a year, 2 years after their treatment, whatever their treatment is for lung cancer. Because I think as cure rates go up, we really need to think about maintaining that physical activity. Just one last piece on a burgeoning topic, the digital divide. You may have heard a lot about this. The digital divide is the notion that as technology becomes incorporated more and more so into every aspect of life, including medicine, that disparities with respect to race, ethnicity, socioeconomic status, that are also associated with gaps in terms of having mobile devices, smartphones, broadband, Wi-Fi, that these disparities are going to be exacerbated if we're saying that wearables and smartphones are going to improve health outcomes and some of our patients don't have them, can't use them, can't afford them. That may actually end up increasing disparities in our field. So we looked at that in our data and did find a little bit of a hint, not with specifically race or ethnicity, but actually with socioeconomic status. Looking back at our first few hundred patients from our trials, we did find that patients in the highest SES groups were more likely to have complete data compared to those in the lower SES groups. And that actually did correlate dramatically with adverse events, in particular hospitalization during radiotherapy. And this is something we've seen in other studies, at least in the Bronx as well. The patients with low SES end up being at far higher risk of hospitalization during related to treatment complications. So this is something we're actively looking to study in greater detail in the Bronx, and I think we should all be aware of this as these things become more and more routine. So here's my crazy slide again, just to show that there's a lot we have to learn and lots of research opportunities. You know, my first study in this space was started with very little funding, just a few $1,000s, and I think it's really a ripe area for all kinds of research. No matter what disease site you're going to be treating, no matter what setting you're in, urban, rural, what kind of patient population, I think there's a lot of interesting things that can be done as technology improves. So you guys should all start drinking the Kool-Aid as well. And with that, I'll stop and leave some time for questions, comments. Thank you all again for your attention.
Great. Thank you so much, Dr. Ohri. That was a really fascinating talk with a lot of interesting data. And I know, speaking for myself, I just think it's so intriguing that we could use something that we haven't really thought of before as something that we can use as interventions. Usually it's our general gestalt of looking at a patient on how they're going to do, the usual blood pressure, heart rate, and now there could be something else out there that can be such an incredible intervention to help our patients. So thank you so much for really a wonderful talk and opening up our eyes to a new area of oncology. So we have about 15 or so minutes left for questions. Please feel free to put them in the chat. We can present them to Dr. Ohri. You also have the capability to unmute yourself or raise your hand function, and we'll call on you. Open up to the floor. So while we have some people waiting and waiting for questions, Dr. Ohri, what I found really interesting was in your, I think it was your 2019 study, when you were trying to intervene with patients that you saw might be getting into trouble. And one of the reasons why maybe it wasn't super successful was patients were actually taking off their device to not bring attention to themselves and not having those extra doctor's visits. And yeah, do you have any more insight into that? Because for me, I would think that that's like the number one thing that all patients want to avoid. Patients hate the hospital, they hate the ED, they hate the experience, the experience of being admitted. So I would think they would want to do anything and everything and welcome that extra attention from their physicians and that hand holding that you were trying to provide. So
yeah,
no, I think it's comment on that.
No, it's a great question, and I think a couple of things were happening. One, we're excited to move forward with our second study, and we were basing that on pilot data from a study of 38 patients, and came up with a metric of how much is your step counts and how much is it going down, and sort of a little formula to say, are you at risk for hospitalization? And while it was pretty sensitive for finding the patients who are at risk, it was not very specific, meaning many patients were having low step counts, but still kind of would end up doing okay. And so I think, while step counts are, I think, very powerful, they're just the tip of the iceberg. And that's why I think partnering with Dr. Hong's team to do some more nuanced analyses to give a real risk profile for each patient that's both objective and dynamic will help us sort of target the patients who are really at risk, and then perhaps then we won't have so many patients sort of frustrated by that extra attention. The other thing, it's sort of an example of the idea of that, like, sort of missing data is not the same as the absence of information. So to me, if I would see a patient who took off their device and says, oh, oftentimes it'll be like, oh, I knew I wasn't moving much, so I just took it off. So that's sort of a telling thing as well, that patients may realize that they're either sort of, they're not feeling well and don't want you to, are sort of ashamed or feel like they're letting you down, so they take off the device. So there's a lot that they could be thinking.
Interesting. Yeah, thanks. Any other questions?
Maybe I can pose a question. Maybe if you could do a show of hands with this little raise hand thing.
Sure.
How many of you guys in the audience are using wearables these days? I know Dr. Bernstein has a new one. All right, so it seems like it's a minority of us. Okay, and then, okay. Great, and do any of you guys have any experience, Dr. Bernstein, if you see a patient in clinic who has a device, would you think to ask what are the step counts like, or?
I haven't. I saw my main practice is breast cancer and prostate cancer. I do have a breast cancer patient in her 40s with DCIS who had a wearable device, and we sat and chatted about it a little bit. So I think now she just started treatment, so I think I will make that a part of my weekly status check and see if she's seeing any change. I don't expect it based on the patient population and treatment, but definitely I think it's an important question now to ask, and I'll keep my eye out for it.
Yeah, actually, just to that point, we had there's a study from the Pittsburgh group led by Dr. Champ out when he was out there using wearables during breast cancer radiation, and the step counts actually were quite solid. They did not, I mean, I think statistically they declined by like a few steps per week, but it wasn't really clinically significant.
Interesting.
Dr. Ohri, this is Dr. Kaushal. I'd like to actually ask a question. It was a really just great talk.
Okay.
And I'm a TJ alum too. I was probably about 3 or 4 years before you, but I just wanted to say hi.
Okay.
I wanted to ask, so this kind of falls under the bigger rubric of, I guess, integrative oncology in terms of, kind of lifestyle management, if you can think about it that way. What are your thoughts about, what would you like to see done in terms of other areas that we can intervene as radiation oncologists? One of my concerns and frustrations is that once I left the East Coast, and I mostly have grown up on the East Coast, I'm actually at the University of Kentucky right now. The baseline lifestyle in terms of overall health, diet, exercise, dental care is definitely a bit different. What do you think are kind of, the next frontier in terms of, targeting an area that we can intervene in nutrition, kind of, very quantifiable the way you've done with step count and things like that? What do you see what would you like to see on the horizon?
I think it's all possible. I think, specifically the tech can help enable things, but we need to do it sort of intelligently. We need to sort of tailor the devices and the apps to the patient population. Certainly the types of diet plans a patient in Kentucky may be willing to accept may be very different from a patient from the Bronx who, may be from an ethnic or racial minority. So all these things need to be considered. Unfortunately, I don't think there'll be sort of a one size fits all approach.
Right.
And then specifically to the physician side, it's sort of, we can spend our time, we're focusing on diet, on activity, on adherence to medications. I think there's so much where we kind of know what's the right thing to do, but we often don't do it or don't achieve it, and we know it's not happening. But the incentives from the patient side or from the physician side are not necessarily there to, to focus on these things, and or maybe this just is not an efficient thing. If you, adherence to oral medications would probably be improved with these smart bottles. So all these things I think can be hopefully streamlined to be done more efficiently, so that we can all, do it and have, there's only so much time in the day, so that's where I think hopefully the tech will help us.
Have you done any? Oh, sorry. Go ahead. I'm sorry. I didn't mean to cut you off. No, finish your thought.
No, that's it. Go ahead.
No, I was going to say, have you done any? It's hard to quantify, and you're right. You're absolutely right. You bring up a whole thing about how it has to be couched in terms of what the patient's going to accept, and that'll vary largely, also vary geographically and by ethnic background and foods that we eat. Have you done anything quantifiable in terms of caloric intake or seeing what patients do, calorie wise, or with intermittent fasting that they're already doing, and we as radiation oncologists, perhaps haven't inquired about because we're trying to take care of so many other things? Have you done any, have you looked into that at all?
So I personally have not focused on that. One of my colleagues, Dr. Garg, is very interested in that and has developed an app that will, we're starting a second study. We did a pilot study already that patients will use during a radiation course, and will actually suggest specific meal plans and different things, and has a interface where the patient can have an ongoing dialogue with the dietitian to help manage issues regarding what should I eat, what shouldn't I eat. So that, I think that's going to be a step in the right direction. That one in particular is nice because it's sort of customized to our patient population and sort of the things in the normal or usual diet there. And I think the next step was we sort of brainstorm is to integrate that with an activity component and build that all in together to give a sort of more holistic, interface with the patient.
Yeah, I agree. Well, great talk. Thanks for giving it.
Well, thank you.
Oh, I had a quick question. What do you think the most significant, like technical or clinical barrier to prevent broad use of these devices? Is it mostly just patient buy-in to actually using wearable devices?
I think it's almost more the time than anything else. So if we, many devices are pretty cheap. We can figure out a way to gather the data. Many patients have Wi-Fi and broadband and stuff. Even if they don't, our clinics do. We can get the data one way or another. I think, from the clinician side, there's just so much information coming in that we need to be cognizant, of course, if we're going to make this routine, that every patient's going to have step counts considered, activity data considered. It needs to be streamlined into the process so it's not extra work for the clinicians, for the physicians, hopefully not too much extra work for the nurses or somebody else. And so to do all that, it just, we need to make it a process that the people are happy to participate in, both the patients and the clinicians. With bigger studies, hopefully we'll prove that measuring these variables actually improves outcomes and yields better clinical outcomes and some kind of cost savings. Probably thinking cynically, it would help if there were some billing codes associated with this stuff. That might get more people's attention.
And do you think this is just mostly going to be integrating like currently commercially available devices, or should there be like an effort from the NIH or someone to develop their own kind of customized device?
I think the commercial devices are quite good, and I can't see that there are medical devices out there, but they don't do much better necessarily, and they're often not as durable and user-friendly. So I think the commercial devices are going to give you most of what you need.
Great, thank
Maybe
you.
that's my bias.
Dr. Ohri, I had a real quick question. When you were showing your initial data, pre-treatment step count, you were saying seems to be predictive, maybe even better than ECOG or KPS on maybe making treatment decisions. Do you think, or have you experienced any pushback from medical oncology, surgical oncology, and saying in making your treatment decisions to say, well, X, Y, and Z might be true, but this patient's step counts pre-treatment is in the 2000s. Maybe we shouldn't embark on a 6-week chemo RT course. Maybe we should do something hypofrac. And they might say, well, basing it on what? Do you think there's going to be any pushback from that, using this as a treatment?
Yeah, I think I haven't got that far yet. I mean, we've had this finding, and I haven't got that far yet to actually change the recommendation, especially, if you have one metric, the step count telling you this patient's performance status is really 3 or 4, but then you have a history of randomized trials showing a 5% survival benefit if you had chemo to the radiation.
Right.
Where do when do you start trying to talk people out of doing that? And so that's a touchy subject. So I think we need to sort of validate that in a bigger sense. I think we are in this the next NRG big lung study, LU008. We are building in some metrics to collect activity data during that study. So that'll be a big randomized study with 300-400 patients, where maybe we'll get to validate that finding. And that study actually will be the first in big NRG study for lung to include performance status 2 patients. So we'll get I think a nice demonstration of the fact that performance status and step counts are really not equivalent.
Great, thanks. Any other questions from the audience in the last couple of minutes?
I guess like one quick question.
Sure.
Again, are there any regulatory challenges that you think would happen from like the government side for making this like rapidly adopted for clinical use?
I don't think so. I mean, the sort of the step counts are not considered PHI, is my understanding. So that's helpful, even though there's some studies showing that you could really, if you wanted to, by looking at somebody's activity data, basically, it's almost like a fingerprint. But still, step counts are not considered PHI. So no, I mean, I don't perceive any major regulatory issues, especially if what are you comparing this with? Performance status is very arbitrary. So no, I don't, if I think so far.
Yeah, I guess if they like include like heart rate, other measures besides just step counts.
Yeah, I mean, you'd want to make sure that your measures are fairly reliable with whatever device you're using. There's lots of studies comparing the different brands of pedometers and medical grade accelerometers and actigraphy, showing that a daily step counts, maybe they vary by 5 to 10% or so between devices.
Yeah.
Which in the scheme of things, if you look at a patient who's averaging 6,000 steps and then in the middle of chemo RT is down to 1,000 steps, a few percent is not going to mean anything. And also, if you get into the idea of looking at each patient as their own control and looking at the trends over time, the device-to-device variability shouldn't matter.
Sure. Okay.
Great. Well, we're just about at 4:30 here on the East Coast. So just want to take another second to thank Dr. Ohri for truly a really fascinating and marvelous talk and seemingly practice changing. So thanks so much for taking the time and presenting all of your data to us, and keep us posted on the future. It seems like it's going to be extremely exciting. And thanks for everyone for joining. Just as a quick reminder, this meeting has been recorded, so feel free to access it at your leisure, pass it along to any of your colleagues that were not able to make it during this time. The past ones you'll also find are also recorded. Please keep your eye out on your email for our future monthly webinars that are coming out by ACRO. And just a quick plug that if you were not able to attend the ACRO annual meeting in March, you can still go to the ACRO website, access all the content for the fantastic talks that were delivered, and also access the SAMs for your credit if needed. So thanks everyone for joining. Have a wonderful rest of your afternoon and see you next month. Thanks again, Dr. Ohri.
Thank you guys. Have a good day.